Welcome to the online anatomy reviews. This is session 27, and now we're going to discuss the abdominal cavity and its development. The abdominal cavity is really the abdominal pelvic cavity, and it's one large area composed of the abdominal wall with the lateral and anterior segments, and then it's bounded superiorly by a thoracic diaphragm and inferiorly by the pelvic diaphragm. So it's going to contain all of the organs of the abdominal wall, and it produces intra-abdominal and pelvic pressures through the apposition of those two diaphragms. The GI tract is basically a tube that's 18 to 22 feet, and it's broken down into several components: the esophagus, stomach, and the omentum. Associated organs including the liver and its gallbladder, pancreas and spleen, the small bowel, which would be the duodenum, jejunum, and ileum, and then the large bowel, cecum and appendix, ascending, transverse, descending, sigmoid colon, the rectum, and then finally the anus. Now each of these divides by these lines shown here into a foregut, a midgut, and a hindgut, and this is set up very early in the embryo, since this starts as a very midline short tube down the length of the embryo, and that's set up as a result of folding. As we look at the development of the GI, we'll start at the folding point of day 20, and it starts and completes by day 84. At the end of the third week, the craniocaudal and lateral wall folding will encase and enclose the endodermal gut tube. On the gut tube, there'll be cystic diverticuli that form the pancreatic buds and the liver buds. The stomach will form as a foregut expansion, and then it will begin to rotate 2 times. The greater omentum will expand off, and the cloaca will form as the stomach starts to complete its rotations. And then the lesser sac appears as a fusion of the duodenum posteriorly. At week 7, the primary intestinal loop of the small and large bowel continuation will herniate into the umbilicus, and it will rotate while it's out into the umbilicus. It rotates 90 degrees counterclockwise. And then the cloaca will be split off in the hindgut as a urogenital sinus and an anal-rectal canal. By week 11, there's going to be another 2 rotations of 90 degrees each, which will complete the 180 more degrees of rotation that midgut needs to take as it retracts back into the abdomen. And then by week 12, the ascending and descending colons and some of the other portions of the bowel that will become secondarily retroperitoneal will become fixed to the body wall. In this section, you can see the foregut, midgut, and hindgut that are a result of that folding. Notice how the midgut is still open to the yolk sac. This GI tube will grow into the serous peritoneum that's around the abdomen, and it will be suspended by this peritoneum by the ventral and dorsal mesogastrium. Here's a view that shows a cross-section showing where the dorsal and ventral mesogastrium will set up. The stomach, which is noted as the gaster for G, is going to have everything in front of it being ventral mesogastrium, which includes the hepatis or the liver, and then the vitelline vein or the umbilical vein. Posteriorly, there's the spleen and the pancreas, which are suspended by the dorsal mesogastrium. Everything that pushes into this peritoneal sac is at one point in development intraperitoneal, which really just means it's covered by a visceral peritoneum and it's suspended by a mesentery, which is 2 layers of peritoneum. There's 2 types of retroperitoneal, which really just means behind the peritoneal sac. If you're primarily retroperitoneal, like the kidneys and the aorta, then you've never grown into this peritoneal sac outlined in red. But if you did grow into it, and then later on in adult life you'll anchor down using a fusion fascia, that means that you're going to be secondarily retroperitoneal. This chart is just a series of reminders of which structures are peritoneal, retroperitoneal, or secondarily retroperitoneal. Let's do a question. A posteriorly perforating ulcer in the pyloric antrum of the stomach is most likely to produce initial localized peritonitis or abscess formation in the, we're looking for omental bursa. The omental bursa is also known as the lesser sac, and it is located posterior to the stomach, inferior to the liver, superior to the pancreas, and lateral to the spleen. Let's take a look at the formation of the peritoneal spaces. In green and blue you can see the ventral mesogastrium and dorsal mesogastrium respectively. The ventral mesogastrium in green will disappear except for that central portion between the stomach and the liver. That will become the roof of the lesser sac, and that will be the potential space behind the stomach, and oftentimes referred to as the omental foramen, as the only entrance into it. This is a potential area for the collection of infection and fluids that needs to be drained through that omental foramen. The greater peritoneal sac will be the rest of the abdominal pelvic cavity. They'll be divided into subphrenic recesses, which are potential peritoneal spaces between the liver and the inferior surface of the diaphragm, where there can oftentimes be collections of infective materials. The hepatorenal recess, or Morrison's pouch, which is a potential space between the right lobe of the liver and the right kidney. The lowest point of the peritoneal cavity in the supine position is this Morrison's pouch. The paracolic gutters will lie on the sides of the ascending and descending colon, and they will extend down over the pelvic brim and into the pelvis, which can actually cause infectious materials to pass from the abdomen into the pelvis itself. Here, in a sectional view or sagittal plane, you can see the peritoneal ligaments and mesenteries as in the adult forms. All of the stippled red areas are the peritoneal cavity, which is a very low level of peritoneal fluid that exists in the cavity space, and then in black you can see the lesser sac. Now there's two types of ligaments that will connect all of these structures. There are ligaments that are organ to organ, or there are ligaments that are organ to body wall. And really they're not ligaments at all, they're just peritoneal reflection points, and so it's a bit of a misnomer. In the organ-to-organ ligaments, they're named by the organ they come off of to the organ they go to, and oftentimes there'll be an O in between the two. For instance, there's a ligament from the spleen to the kidney, which is called the splenorenal, or the lienorenal, which is the older term for spleen. For those that go from organ to body wall, they're named often by their shape. And those would include things like the left and right triangular ligaments off of the lobes of the liver, the falciform ligament, which is coming off the anterior surface of the liver, and the coronary ligament, which will be crowning around the bare area of the liver as it anchors to the diaphragm. Here you can see the mesentery, which is a suspension of double-layered peritoneum that will encase the small bowel, and it runs on an oblique angle from the upper left quadrant down towards the lower right quadrant, where it will join to the cecum. Also, the greater omentum, as you can see, has 4 layers of peritoneum, 2 of which come off of the stomach and 2 from the transverse colon that will swing around each other, and there you can see that there are 4 layers of peritoneum, or double mesentery, at that area. Let's do a question. In traumatic injuries, the spleen may be ruptured and result in massive internal bleeding. In an emergency splenectomy, clamping of which of the following structures would stop the bleeding? The lienorenal ligament is going to be of importance because of the vasculature that will run through it, including the splenic artery. Here is a list of peritoneal ligaments and the mesenteries that encase them, and we'll just let you look at these on your own time and get a feel for the major ligaments of the abdominal cavity. Now we'll move on to the rotations of the stomach. Developmentally, this midline gut tube, that's foregut, midgut, and hindgut, will start to grow in different directions, and that will give the appearance of a rotation. After the caudal foregut starts to develop, it starts to grow very rapidly posteriorly. and then it's going to start to rotate around a longitudinal axis, which will then put the omentum towards the left side and the greater curvature towards the left as well. And that will be a rotation around a longitudinal axis. In the second stage of rotation, it will start to go clockwise around an axis that is in the AP direction. Here you can see the longitudinal axis, and here you can see the AP axis. As it rotates around 90 degrees in clockwise direction from this AP axis, it will rotate the duodenum up towards the right, it will rotate the developing liver up towards the right, and it will rotate the spleen and pancreas that are developing over towards the left. This will then bring the omentum down into an anterior position as it hangs off of the greater curvature. The enclosure around that axis of rotation towards the liver will also swing the lesser omentum over top of the lesser sac. A 1-week-old baby was brought to the clinic by his anxious mother. There was excessive accumulation of saliva and mucus in the nose and mouth of the baby. She described episodes of gagging and the baby turning blue after swallowing milk, as well as the abdominal distension after crying. The physician was not able to pass a catheter into the stomach, and plain X-ray of the abdomen showed air in the infant's stomach. Physical examination of the chest showed signs of pneumonia. Which of the following congenital anomalies could be the cause of this condition? This is a question that you have to look at a few different keys that are showing up. One is that there was an accumulation of saliva and mucus in the nose and mouth of the baby, and the gagging without an accumulation of large amounts of food and not vomiting will be a sign that there's a short pouch. There's also difficulty passing a catheter, which means there's probably an atresia. If you look at the chest, you're getting air into the stomach, but with an atresia there must be another way of connecting the two, so you're also thinking about a fistula. And the only option in this one that has a fistula and an atresia is E, the esophageal atresia with a fistula between the end of the esophagus and the trachea. The gagging and coughing would be the associated fistula that has a connection to the developing trachea. Here we can look at a few of those developmental problems. The first is this esophageal atresia with a blind ending esophagus and a fistula that goes from the trachea. This is what we'd have in the scenario prior. Then you can see that these two scenarios are not going to allow the baby to feed, and they're certainly not going to gain weight as quickly. In these two options, where you have a fistula that has a direct pathway at least to the stomach, this will allow a little bit slower weight loss, so they won't be digressing as quickly as if they had options A or C. So there's a couple possibilities. One is that we have option D in this scenario, or we could have option A. The most likely of these two, because there is air in the stomach, would be option A. The duodenal malformations are also going to be significant, and you can get an atresia usually through some kind of vascular infarct that occurs during development, and you can have a dilated duodenum. Notice how the dilation is in the second part of the duodenum. This would be after all of the bile and pancreatic enzymes have been added in. So if the infant is having vomitus, this would be a bile-containing vomitus in this scenario. In the second option here, you can see a duodenal atresia with no lumen at all. Sometimes this again can be from an infarct event, or it can be from a failure to cannulize during the swallowing of the embryonic fluids. So if the baby cannot swallow fluids at all, there's going to be polyhydramnios affected with the pregnancy. Post-pregnancy, there's going to be vomitous bile present. Here's an ultrasound showing such an atresia or stenosis. The double bubble sign is a classic sign where you get a dilation of the duodenum and, of course, the regular dilation of the stomach with the narrowing of the sphincter of the duodenum that is between the two. You can also see that double bubble formation in a transverse scan where you get a clear separation of the stomach and the duodenum. Notice how the duodenum is almost the size of the stomach, and that would not be normal. Let's look at the accessory organ formation. The liver forms around mid-third week after a hepatic diverticulum comes off of that caudal foregut. The endodermal epithelium will form hepatocytes and a biliary tree, and it will grow up into the septum transversum, which is portion of the diaphragm, which will form the connective tissue and the hematopoietic cells and Kupffer cells, or macrophages, in the liver. This will also interact with the forming heart, so there's some crosstalk between the developing liver and the forming heart, which will ensure that the IVC is associated with the liver's formation as well. The pancreas will have both a ventral and dorsal diverticuli. The ventral diverticulum will swing around the duodenum during stomach rotation and forms the inferior head and the uncinate process. The dorsal will swing around from the superior portion and form the superior head, body, and tail. The pancreas will become active in secreting insulin by 10th week. And this is going to be something that is important because if the mother is diabetic and is having trouble with maintaining sugars in the body and carrying too much of it in the blood, the baby will start packing away the sugars as energy and will grow too big, so you tend to have a very large fetus as a result of uncontrolled diabetes in the maternal sense. The spleen is not a foregut-associated organ, although it is closely associated because of the vascular supply, but this one forms in the mesoderm around the 5th week. It's going to proliferate into dorsal mesentery, and it will connect to the kidneys and stomach via those mesenteries. If you have a 33-year-old female suspected to have liver problems because of the referred pain she's reporting along the right during imaging, the radiologist noticed the cecum below the right lobe of the liver in the right hypochondrium. The ascending colon was absent. What is the probable cause of this anomaly? In this particular developmental anomaly, there will be a failure of the 3rd stage of rotation of the midgut. And we're going to look at how those proceed. There's going to be a total of 270 degrees of rotation of this midgut in 3 stages of 90. The first set of rotations, stage 1, is going to be the physiologic herniation that occurs out into the umbilicus. At this point, the GI tract is starting to grow so prolifically and quickly that there's not room for it in the small intraembryonic coelom, so it herniates into the umbilical cord. And then there'll be a cranial and a caudal loop of this midgut that herniates out into the umbilicus. After it does a 90-degree rotation around the central axis of the yolk stalk, it's going to set it up so that there is a left and right rotation to the small bowel. The large bowel will form at the caudal end of the loop, and the small bowel will form at the cranial end of this loop. So 90-degree rotation will turn it to the left and right instead of cranial and caudal. The next thing you can see here is that the umbilical artery in this ultrasound scan using Doppler imaging will actually show that physiologic herniation of the midgut into the embryo's umbilical cord. And you can see that the umbilical cord is about half the size of the entire embryo in this view. In the second phase, we have to get through another 180 degrees of counterclockwise rotation, and this is going to occur as the midgut starts to pull back into the abdomen, which it really doesn't do. It's actually the abdomen starts to now encase the umbilical cord as it starts to catch up to the growth rates of the gut tube. So it has a left-right orientation to start this rotation, As it pulls back, it undergoes another 90-degree clockwise rotation as phase 2 starts around week 10 and 11. This recoil of the herniation is going to signal the rotation so that the cecum and the appendix end up just underneath the forming liver and gallbladder. If it stops here, you can see this is the scenario that we had in the first question that we discussed just a few minutes ago. Because there was a failure of the third rotation, it ended up with a subhepatic appendix, which is why the appendix and the appendicitis can be difficult to diagnose, because it can be anywhere from under the liver to being on the right side or the left side, and then down in the lower quadrant or in the upper quadrant. So the next stage, after the appendix has become subhepatic, it has to make a final rotation of 90 degrees to put it into its adult placement. And that will take the cecum and the appendix down into the iliac fossa, and that will put the ascending colon along the right side and the descending colon along the left side, where they will fuse down to the body wall. It will also put the colon over top of the duodenum, unless it gets rotated under the wrong way, in which case the duodenum can be stuck over top of the colon, and this can cause infarctions and rotational problems later on. The caudal foregut and midgut rotations, as a reminder, will start like this. First, the foregut will rotate 90 degrees clockwise along a longitudinal axis, and then it will grow posteriorly faster than it does anteriorly. This first rotation will push the greater omentum and greater curvature to the left. The second foregut rotation will be another 90 degrees, but along a different axis. This time it will rotate 90 degrees along an AP axis, which will push the duodenum and the liver up to the right, forming its classic C shape. Then the midgut starts to rotate. It starts by pushing into the umbilicus as a long U-shaped primary gut loop around week 6. It will be attached to the yolk stalk at this point and have cranial and caudal limbs. The peritoneal cavity is going to be too small for this midgut, therefore it has to herniate out, and that will do that at the week 6. And then the midgut will start to pull back after its first rotation, and the cranial loop will grow much faster as the small intestine than the caudal loop will as the large intestine. It will rotate another 180 degrees in 2 sets of 90, both of which are counterclockwise, as it pulls back into the midgut around week 10 or 11. And then finally, that will make sure that the bowel is in its normal adult position. Let's have a reminder of what it forms. We know the tract of things that it forms as we discussed as we began this section, but we know in general it has a foregut, a midgut, and a hindgut. I like to remember the pattern for learning purposes of 6-6-3. 6 things I want to remember from foregut, 6 things I want to remember about midgut, and 3 things I want to remember about hindgut. Remember, the aortic descending aorta is directly behind this. The midgut, foregut, and hindgut will push into the mesentery, but that aorta will remain retroperitoneal primarily. So what are the 6 portions I want to remember? 3 of them in the foregut are tube, and 3 of them are associated organs. First we have esophagus, then stomach, and then the proximal half of the duodenum. And then the associated organs I want to recall of foregut are going to be pancreas, liver and gallbladder, and the spleen, which is not really a foregut organ, but it is associated vascularly. Then the 6 things I want to remember in the midgut are the portions of the duodenum that's the last half, then the jejunum, ileum, cecum and its associated appendix, ascending colon, and then the transverse colon. Notice how I've left a space towards the end of transverse. That's to remind me that a portion of the transverse colon is really hindgut. So somewhere along that distal portion of the transverse colon there's a transition from midgut to hindgut. Then we have 3 portions of the hindgut to remember, all of which are tube, descending colon, sigmoid colon, and rectum. So as the aorta sits behind it, it will feed all of its vascular structures into the foregut, the midgut, or the hindgut, so that when this turns into its 18 to 22 feet of tube, it will drag out branches with it from those main arteries, and those will be unpaired vessels. The first of which, feeding the foregut, is known as celiac, and all of the branches to the esophagus, stomach, duodenum, pancreas, liver, and spleen will be off of the celiac. And the superior mesenteric will supply those 6 portions of the tube that are in the midgut, and the inferior mesenteric vessel will supply those 3 portions of tube that are in the hindgut. All of this tube will be in a peritoneum, so it will at one point be peritonealized, but eventually components of this, such as the ascending and descending colon, will anchor down and become retroperitoneal secondarily. Concludes the section on the abdominal cavity and development. In our next segment, we'll talk about the abdominal organs.